Kia ora and welcome to Goodfellow podcasts. This episode is supported by an unrestricted educational grant from Mercy Ascot. The content of this podcast was developed independently and the views expressed are those of our expert speaker. I'm Dr. Louise Kugler, a specialist GP, and today I welcome to the podcast Rajan Patel to discuss red flags in the neck lump of your adult patient. This episode acknowledges World Head and Neck Day, which falls annually on the 27th of July. Rajan is the New Zealand convener for World Head and Neck Cancer Day and has been involved in head and neck cancer treatment for 20 years. He qualified as a consultant head and neck surgeon in 2005, and he was awarded a Doctor of Medicine diploma by the University of Glasgow for his research efforts. Thereafter, he completed 3 years of fellowship training in head and neck surgery and reconstructive surgery in Toronto and Sydney. He is currently the clinical lead surgeon at Auckland Head and Neck Surgery, and he is part of the Mercy Ascot Head and Neck team. Kia ora, Rajan, and welcome to the podcast.
Thank you, Louise.
So, an adult patient presents with a neck lump. What key information should we gather from our patient?
Well, Louise, a lump in the adult patient is a relatively common presentation to GPs. And what we have to be mindful for is the more sinister or serious conditions that may present with a neck lump. And clearly that's malignancy. So if we just think about the differential diagnosis of the malignant neck lump, that can help us understand what are the key features of the patient's history and examination we need to elicit. So malignant lumps primarily are malignant lymph nodes or other structures. Malignant lymph nodes include a primary cancer originating in the lymph node, otherwise known as lymphoma, or secondaries. And these are metastases from other sites where the origin of the cancer is. And these are typically in the head and neck region, either on the surface of the head and neck, so the skin, or the inner lining of the head and neck. That's the mucosa of the oral cavity, nasal cavity, pharynx, and larynx. Additionally, but less commonly, malignant neck lumps can relate to salivary glands. However, whilst it's important for us to remember the malignant differential diagnosis, by far the majority of neck lumps that present to you in the GP community in adults will be benign diagnosis, particularly reactive or inflamed lymph nodes. So anyway, with that in mind, we just need to consider some of the features that may herald a malignant diagnosis. And these are very well accepted and well documented throughout the world, both here in Australasia, but also in Europe and other countries. And it's fairly uniform. So the features are essentially a lump that persists for more than 2 or 3 weeks, clearly benign reactive lymph nodes that we all suffer from time to time, particularly with upper respiratory tract infective type illnesses, tend to disappear or at least start resolving after several days of illness. So we're really interested in those patients who have a more persistent neck lump, a lump that's been present for 2 or more weeks. And then with consideration of the differential diagnoses of malignant neck lumps that I mentioned, we also need to think, are there any associated symptoms that may direct us to thinking, well, this lump may be a secondary from a primary inside the head and neck. And so that could include either a change in the voice that may herald a larynx cancer, sore throat, directing us to consider a pharyngeal cancer, stridor, difficulty breathing, again, upper airway, either the trachea or larynx. And then other symptoms, change in swallow, either painful or difficult swallow, ipsilateral otalgia. This is a very interesting symptom. Ipsilateral otalgia in the absence of any other symptoms or signs, such as a discharging ear or foreign body in the ear or other features, is always a very concerning presentation, and that relates to referred pain from the upper airway. Typically, a malignant diagnosis in the upper airway can cause referred pain to one side and presenting as otalgia. Similarly, unilateral nasal obstruction or unilateral epistaxis associated with some of these other symptoms is worrisome. And then if we're considering lymphoma, well, there are a bunch of constitutional symptoms, rigors, fevers, weight loss, etc., that may make us consider lymphoproliferative disorders. Clearly, if the patient has infective symptoms such as high temperature, sweats, fever, an abnormal looking throat, such as tonsillitis, purulent tonsils, and a neck lump, then that's more in keeping with a benign diagnosis. And so when we're examining our patients, we need to look not only at the lump in the neck, but also those structures that I mentioned may be relevant, particularly for a malignant diagnosis. We want to look at the skin of the head and neck. Are there any obvious suspicious lesions, anything that looks pigmented like a melanoma or ulcerated, suggesting a carcinoma? Look in the mouth, the tongue, the oropharynx, looking for mucosal lesions, asymmetrically enlarged tonsils in the absence of infective symptoms. It is also a worrying presentation in the presence of a neck lump. And finally, cranial nerve palsies. And perhaps the most common of all of these is a facial nerve palsy that I'm sure many of our listeners will have seen in their careers. And whilst the diagnosis may be inflammatory or infective, Bell's palsy, one always has to be mindful that this may be a presentation secondary to a cancer. And indeed, this morning in my clinic, I saw a patient with a facial nerve palsy who also has a parotid lump, and he has metastatic SCC, squamous cell carcinoma, from previously treated skin cancer, causing facial nerve palsy.
Thank you for that detailed overview, Rajan. So thinking about risk factors for head and neck cancers, what are these?
Well, when I started in head and neck cancer, our head and neck clinic waiting rooms were typically filled with patients who were heavy smokers, abusers of alcohol, didn't eat fresh veg and fruit. You know, they were a fairly typical population in the clinic weight room. But things have changed a lot now. You know, certainly in the Western world, fewer people are smoking, fewer people are abusing alcohol, particularly spirits. But we're still seeing these patients in our waiting room with head and neck cancer, and the demographic of the patient has changed somewhat. We're seeing younger patients who are not smokers and not abusers of alcohol, and who live what would be considered a healthy lifestyle. And so we've seen an explosion in that population of patients, and we now know that the cancer is related to something called HPV, human papillomavirus, that many of you will be familiar with as risk factors for other cancers. So to answer your question, yes, smoking is still a risk factor for head and neck cancer, as is alcohol abuse. But just because a patient doesn't present with those habits does not mean that they are not at risk of head and neck cancer. So currently, by far, the majority of the patients I treat are not smokers and not alcohol abusers, and their cancers are related to human papillomavirus. Additionally, patients who tend to get head and neck cancer tend to be older than 40. It's very unusual to develop head and neck cancer under the age of 40. Having said that, there's always exceptions. A couple of years ago, I treated a patient who was 16 who had a tongue cancer, tongue squamous cell cancer. And I've treated a bunch of patients in their 20s also with tongue cancer. So, you know, there's no hard and fast rules about age, but anyone over the age of 40 with a neck lump or suspicious red flag symptoms or signs, we have to consider head and neck cancer. Additionally, clearly, if the patient has a past history of head and neck cancer and is now presenting with red flag symptoms, then one has to be mindful of either a second primary or a recurrent head and neck cancer. And other thing to be mindful, particularly in New Zealand, is if patients have a history of cutaneous, either melanoma or squamous cell cancer, then one has to be mindful that they may be presenting with a neck lump that may be metastatic disease from that previously treated head and neck cutaneous malignancy.
Rajan, in New Zealand, are the populations that are more commonly affected, thinking perhaps Maori and Pacific people?
We certainly do see a disparity in incidence of one particular cancer in Pacific and Maori population, and that's nasopharyngeal cancer. The most recent data suggests that a Pacific origin patient has a 20 times greater risk of developing nasopharyngeal cancer than a European patient, and Maori about 4 times the risk of a European. And that's thought to be related to the origin of particularly Pacific Islanders, and less so of Maori, and their origin from Chinese populations, migration over many years in Chinese and the Southern Asian population. Incidence of nasopharyngeal cancer is high, and it's thought to be that genetic link between the Chinese and Pacific and Maori that has us see a much higher incidence in that population of patients.
I wonder if we can please now touch on the red flags. So, what are the red flags we need to consider in an adult with a neck lump?
Well, these again are very well documented in a number of guidelines, and they're very uniform. There's no real debate about what should and shouldn't be included in red flags, particularly for neck lumps. And they're a relatively small number. So, and a lot of them are common sense, actually. So, any neck lump that's increasing in size clearly needs attention. As I mentioned earlier on, many neck lumps in adults are related to inflammatory causes that tend to reduce in size relatively quickly in a short period of time. So typically after a week or so, many neck lumps are smaller. So we're interested in lumps that are increasing in size and neck lumps that are greater than about 2 centimeters. Typically, inflamed or reactive lymph nodes are smaller than 2 centimeters. We're interested in lumps that are greater than 2 centimeters. And also, if a lump is changing, that is also worrisome. One also has to be mindful that if the patient is presenting with lumps in the neck, one should also examine other lymph node stations, particularly axillary lymph nodes, groins, palpate for splenomegaly, because that may herald a lymphoproliferative disorder or lymphoma, along with some of the B-type symptoms, including night sweats, generalized itch, weight loss, and fever.
In Rajan, a persistent neck lump, say lasting greater than 6 weeks, what percentage of these will be malignant?
So this percentage does vary from study to study, country to country, and will be largely dependent on referral practices. When we look at our data at our neck lump clinic, we have data on over 3,500 patients, and our rate of malignancy or incidence of malignancy in those referrals is 10%, 1 in 10. And as I mentioned, there are other reports from other parts of the world that are higher and some lower, but for us it's been consistently 10% over the last 10 or so years.
So, Rajan, you mentioned HPV earlier. Has the HPV vaccination impacted our statistics?
HPV vaccines have been available in New Zealand since 2008 for girls, and only more recently 2017 for boys. So it's a little early to see any impact from HPV vaccination. Typically, these cancers that are related to HPV are occurring in 40 to 60-year-olds. So we still have some time before we hopefully will see a significant reduction in incidence of HPV-related head and neck cancers as those who were vaccinated from 2008 girls and both genders 2017 come through.
So, moving now on to physical examination, what specific signs should we be looking for during our examination, thinking both locally and systemically?
So again, if we're mindful of the worrisome diagnosis that we need to identify and not miss. So I mentioned that neck lumps that are malignant are either metastases from the surface or the skin of the head and neck or the mucosal surfaces of the head and neck. So one should really look at those areas. And oftentimes it's very obvious if the patient has a carcinoma or melanoma on the skin of the head and neck region. And similarly, an inspection with a light of the oral cavity, the lips, tongue, the mucosal lining of the oral cavity, as well as the oropharynx, including the tonsil regions, the posterior pharyngeal wall, and the palate, again with a headlight, usually will identify if there's a suspicious lesion. Similarly, clearly, if the patient is presenting with a neck lump, then we need to palpate the lump itself, as well as look for any other lumps in or around that side of the neck and the other side of the neck. And features that we're particularly interested in, is it a solitary neck lump or are there multiple neck lumps? The size, is it hard or soft? Is it mobile, meaning does the skin overlying the neck lump move freely or not? Does the lump move over the underlying structures, or is it fixed? If either of those assessments suggest that it's fixed, then we are a little bit more worried about a malignant diagnosis. And then lastly, I mentioned earlier on that some head and neck malignancies can cause cranial nerve neuropathy, so it's always a good idea to examine cranial nerves.
Wonderful. Thank you for that. So, does the location of the neck lump provide clues about its potential malignancy?
Yes, it does. Very generally speaking, a lump in the midline, so drawing a line from the under the chin straight down the middle to the suprasternal notch, a lump in that region, the midline of the neck, is generally benign. There are obviously exceptions to everything in medicine, and one of the exceptions is that clearly the thyroid gland sits over the trachea in the midline, and 4%, 5% of thyroid lumps are malignant. However, most thyroid malignancies are curable with very high cure rates in the 95 plus range. So that is quite different from lateralized neck lumps, so away from the midline, where the frequency of malignancy is considerably higher.
So, Rajan, we have a patient and have detected a red flag symptom or finding. How quickly should the patient be referred on?
So that patient should be referred urgently. There is an excellent document issued by the Red Whale Update, and they have a piece on most specialties. I've read the piece on head and neck, and I agree with the recommendations. It's a very succinct document. I would recommend anyone interested in this area to go and seek it out. But essentially, they state in that document that there is no value in referring that patient for any tests, whether it's blood tests, x-rays, scans, if it's going to delay referral. So their recommendation is to refer the patient with any red flag symptoms immediately. The one exception there is, which I don't agree with actually, is sending a patient for a chest x-ray, so you can have that done pretty quickly, and that probably wouldn't delay anything. But really, we don't depend now on chest x-rays to identify for disease, particularly malignant disease in the chest. We're thinking about pulmonary metastases. It's just not sensitive enough. Any patient we see with a malignant tumor in the neck will typically have cross-sectional imaging, CT or PET-CT scan to detect for pulmonary metastases.
Great, thanks for clarifying that. So, who should we be referring to?
So any patient with any of those red flags in the head and neck region should essentially be referred to a head and neck surgeon. Head and neck surgeons, certainly in New Zealand, are essentially ENT surgeons with a specialist interest in head and neck. Not all ENT surgeons do head and neck, but if the patient is being referred to the public hospital, then it would be straight to the ENT department. If it was being referred to any private surgeon, then typically it would be a head and neck surgeon that are well specified in all the health pages, etc.
Wonderful. And often our patients want to know what to expect from their first appointment with a specialist. What is it that we should be telling them?
The patient can expect to have firstly a sit-down interview with the specialist, who'll want to glean all of the details of the presenting symptoms as well as past medical and drug history, etc. And then, for example, in our clinic, what we would do is examine the patient visually and would palpate the area of concern, inspect the surfaces of the skin and the mucosa of the head and neck, including doing a endoscopy, a fiber optic endoscopy via the nose to look at the pharynx and larynx. And all patients with neck lumps come to our neck lump clinic where they have an immediate ultrasound and, if necessary, an FNA biopsy that's interpreted by a pathologist who's attending the clinic.
Wonderful. And if a primary care practitioner was wanting to find out more information on this topic, where would you direct them?
So I mentioned the Red Whale Update series. Again, I think that's a really good publication that's actually produced by GPs for GPs. I've read the head and neck content and it's excellent. And I know that there are a bunch of other specialist services covered in that update. So that's would probably be my number one go-to. Our website has a bunch of information on it, as well as places to go to seek more information. There's also Servant Media have articles on there on head and neck and other specialties. And of course, Goodfellow. Goodfellow is a good resource for head and neck as well as other specialties.
Great. To conclude our podcast today, Rajan, your take-home messages, please, for our listeners.
I think everyone should familiarise themselves with the red flags. It's a fairly easy to remember list. Always consider a malignant diagnosis when an adult comes to the surgery to see you with a neck lump. Remember not just to consider the neck lump, but remember the rest of the head and neck. So examine the skin and the surfaces of their mouth, tongue, lips, and throat. And if any of these patients are presenting with a suspicious or a red flag symptom or sign, then please refer the patient urgently for specialist assessment.
Thank you for your time today, Rajan. It's been a pleasure talking to you.
Thank you very much, Louise.
If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll also find a list of resources used in this podcast on our website, goodfellowunit.org, and get in touch. Email podcast@goodfellowunit.org. Thanks for listening.